Great. I'm going to put your cake on the table.
Okay.
Stroke can happen suddenly, often without warning, in homes and families around the world. Stroke is a leading cause of death and the #1 cause of disability among adults in the U.S.
A stroke occurs when blood flow to the brain is interrupted, either by a clot, called an ischemic stroke, or when a blood vessel ruptures, called a hemorrhagic stroke. 87% of all strokes in the U.S. are ischemic, making them potentially treatable if they can be identified and treated rapidly. Welcome to the American Heart Association's Acute Ischemic Stroke video. During this video, we'll follow one woman's experience as she suffers a stroke. As the case unfolds, watch for important steps in the stroke algorithm, including those to identify and provide early fibrinolytic therapy. We'll also highlight the stroke chain of survival and the 8 Ds of stroke care, which can help first responders and healthcare providers treat stroke patients as quickly as possible. The 8 Ds include detection, dispatch of EMS, delivery to a hospital capable of acute stroke care, the door of the emergency department where rapid triage begins, gathering data from CT scans, a decision about fibrinolytic therapy, drug administration, and disposition of the patient by rapidly admitting the patient to the stroke unit. This 8th D, disposition, is new in the 2010 guidelines. The sooner patients receive fibrinolytic therapy for ischemic stroke, the less likely it is that they will emerge from the stroke with physical and neurologic damage. The American Heart Association recommends that all eligible patients receive fibrinolytic therapy as soon as possible, within the first 3 hours from symptom onset.
For a select group of patients, the fibrinolytic treatment window has been extended from 3 to 4.5 hours. At the time the 2010 guidelines were released, this treatment window was not FDA approved, but it is recommended by the American Heart Association, American Stroke Association Science Advisory.
As our case study reveals, it's essential that healthcare providers work together to rapidly recognize and treat acute ischemic stroke. As you'll see, time is brain.
That was a fun family get-together. Did you enjoy it?
Why, yes. It was nice having everyone together.
Yes, it was.
I especially like the fact that John and Diane drove in from out of town.
Mom.
What a surprise!
Mom, what's wrong? Here, let me help you. Oh, Mom, sit down. Sit down. What's wrong?
Oh, no.
Can you understand me? Can you talk?
You guys okay?
Oh, John, there's something wrong with Mom. I don't know what's going on.
Mom, are you okay?
I was in the kitchen. I was washing dishes. We were talking. All of a sudden, she could barely stand up, and I can't understand a word she's trying to say.
Mom, what's going on? Do you know? All right, look, I think she might be having a stroke. Call 911.
A stroke?
It's okay.
Oh.
Mom, it's going to be all right.
Ischemic strokes happen when plaque due to atherosclerosis collects along the walls of arteries, narrowing the arteries to or within the brain. Like in the coronary arteries, disruption of the vessel wall can cause a clot to form, further narrowing or even occluding the artery. Pieces of clot can break off and travel deeper into the arteries and eventually lodge in a smaller vessel and cause a stroke there. This interruption in blood flow ceases function to the affected brain tissue, leading to a sudden onset of symptoms. One of the most important steps in surviving a stroke is simply recognizing the signs of a stroke and calling for help. Because most strokes happen at home, patients may be alone at the time of the attack or deny their symptoms until friends or family members intervene. That may be why only half of all victims of acute stroke arrive at the hospital by ambulance. They don't see the symptoms as an emergency, delaying activation of the stroke chain of survival and the rapid treatment essential to saving neurologic function. The first step in the stroke chain of survival is activating the emergency response system. This is also the first D in the 8 Ds of stroke care: detection of symptoms.
We think my mom might have had a stroke. Just a few minutes ago.
Rescue 21, this is County Dispatch. We have a possible stroke. 65-year-old woman with notable weakness on the right side of her body and loss of speech. Address is 311 Sunset Drive. Timeout is 2:27.
Because hospital personnel must generally administer intravenous fibrinolytic treatment within 3 hours of symptom onset, sending help early is critical. The second link in the stroke chain of survival is rapid EMS dispatch. This is also the second D in the 8 Ds of stroke care. Patients with acute ischemic stroke are racing the clock, much like patients with a STEMI. The longer these patients are without treatment, the greater their chance for disability and death. Upon arriving at the scene, EMS crews must rule out other possible causes of the patient's condition, such as hypoglycemia or seizure. Patients with acute stroke are at risk for respiratory compromise from aspiration, upper airway obstruction, or hypoventilation. The combination of poor perfusion and hypoxemia will only make the brain injury worse. Both pre-hospital and in-hospital personnel should administer supplemental oxygen to hypoxemic stroke patients. These are patients with an oxygen saturation value of less than 94% or those with unknown oxygen saturation values.
Hi, Mrs. Breeze. I'm Mike. I'm going to help you out, okay? I understand you're having some weakness in your arm and your leg. Is that right? Okay, do you have any pain in your chest or your back? No? Are you having any trouble breathing? Okay, that's good. Is your mom diabetic?
No.
Do you know if she's ever had any seizures?
No, never.
When EMS crews arrive, they should perform a brief medical history and, if allowed by protocol, a finger-stick blood glucose analysis. Crews should then perform a stroke assessment, such as the Cincinnati Pre-Hospital Stroke Scale. This evaluates the patient on physical findings related to neurologic function. The first indicator on the Cincinnati scale is facial droop.
Mrs. Breeze, can you smile for me? Okay.
Facial droop is present if one side of the patient's face does not move as well as the other side.
Mrs. Breeze, can I get you to close both eyes and try to hold your arms out straight?
If one of the patient's arms does not move or one arm drifts down compared with the other, this is a sign of arm drift.
Now can I get you to repeat something for me? Can you say, "You can't teach an old dog new tricks"? Okay, that's enough. Thank you.
If the patient slurs words, says the wrong words, or cannot speak at all, this is a sign of abnormal speech. If one or more of these indicators from the Cincinnati Pre-Hospital Stroke Scale is abnormal, the probability of a stroke is 72%.
At what time did you first notice your mom's symptoms?
Just a few minutes before I called 911.
Okay, so at 2:25 p.m. then?
Yep, that sounds about right.
Okay. What are her vitals?
Blood pressure is 190 over 110. Her heart rate is 110. Respirations are 14, and her pulse oximetry is 95%.
Okay, I think we got a potential stroke. Let's get her over to County Medical right away.
Why not Memorial?
We want to get her to the nearest stroke center. Mrs. Breeze, we're going to take you to the hospital so you can get checked out, okay? Julie, I think it's best if you come with us. You can ride with us in the ambulance.
In this case, EMS personnel have established time zero, and the clock is ticking. EMS, ED staff, and the stroke team now have 3 hours to assess the patient and treat her within the window of opportunity for fibrinolytic therapy. The third link in the stroke chain of survival is rapid EMS transport to a hospital that is equipped to deal with acute stroke. If possible, a family member or friend should accompany the patient to help answer questions. This is also the third D of the 8 Ds of stroke care. Delivery of the patient by rapid EMS transport.
We're ready.
EMS should notify the receiving hospital that a patient with a possible stroke is on the way.
Rescue 21, go ahead.
We're en route with a possible stroke patient. 65-year-old female, has weakness on right side, facial droop on right side, and difficulty speaking. The patient's blood pressure is 190 over 110, her heart rate is 110, and her respiratory rate is 14 without difficulty breathing. Blood glucose level and pulse oximetry readings are within normal limits. The patient's ECG shows sinus tachycardia without ectopy. According to family members, onset of symptoms was approximately 14 minutes ago at 2:25 p.m., and our estimated time of arrival is 5 minutes.
Received Rescue 21. We'll be expecting you. We'll notify the ED physician and the stroke team. Page the stroke team.
Advance notice by EMS crews allows the receiving hospital to quickly prepare for the arrival of a possible stroke patient. Time is brain. There is a limited window of opportunity to evaluate the patient, determine eligibility for fibrinolytics, and start the drugs. This brings us to the fourth D of stroke care, DOOR. DOOR stands for the effective triage of the patient.
Is this our stroke patient?
Yes.
We've been expecting you.
Where do you want her?
I've got her in triage room 3.
Hospital personnel should assess a patient with a suspected stroke within 10 minutes of the patient's arrival in the ED. This should include assessment of the patient's ABCs, airway, breathing, and circulation, and an evaluation of baseline vital signs. In addition, ED personnel should administer oxygen if the patient becomes hypoxemic while en route, confirm IV patency, and draw blood samples for blood glucose, electrolyte, CBC, and coagulation studies. Even though EMS did a fingerstick blood glucose analysis, hospital personnel should review and verify blood glucose results. At this time, ED personnel should also acquire a 12-lead ECG, which may identify a recent myocardial infarction or arrhythmia as a potential cause of the stroke. Among the top priorities of the ED physician is a thorough neurologic screening assessment and an emergent CT scan. These actions make up the fifth D of stroke care, collection of data.
Hi, Ms. Breeze. My name is Dr. Wade. I'm the emergency physician. I'm going to be doing your initial evaluation. Dr. Gardner, a neurologist with our stroke unit, is on the way. Now, I understand that you're having trouble speaking, but I do need to ask you a few questions, if you don't mind. Now, you can nod your head. That would be fine, or perhaps your daughter can answer for you, if that's okay. Okay, good. Now, I understand that you experienced numbness and weakness on your right side. Is that correct? Okay, good. Now, can you tell me what month it is?
November.
And what's your age?
I'm 60.
Okay, that's all right. I'll tell you what I'm going to do is I'm going to lift your right arm, and I want you to hold it up as long as you can. And would you mind lifting your left arm at the same time with me? Okay, here we go. Okay, now hold your right arm as long as you can. Okay, still experiencing a little weakness there? Okay. All right, now we're going to lift your right leg. Now see if you can hold that up for me, please. Okay, still a little weakness there too, huh? Okay, it's okay. That's all right. All right. Now, can you open and close your eyes for me? Good. Now, could you open and close both hands, make a fist on both hands at the same time for me? Do you know about what time your mother started experiencing symptoms?
Yep, it was right after our family gathering at about 2:25 p.m.
Okay, so that was, what, 25 minutes ago?
Yes, that's right.
Okay. Dana, I want to get her a CT, okay, and we can do the rest of the stroke evaluation on the way. Now, was CT notified before the patient arrived?
Yes, we notified them as soon as EMS called. They're waiting for her now.
Okay, good. Let's get Mrs. Breeze down there, all right?
Okay.
There you go.
Mrs. Breeze, we're going to take you down for a CT scan.
An emergent CT scan should be done within 25 minutes of the patient's arrival in the ED. A physician with expertise in CT scan interpretation should evaluate the scan within 45 minutes of the patient's arrival. The CT scan will help determine whether an intracerebral hemorrhage is present, which would exclude the patient from fibrinolytic therapy. If a hemorrhage is present, the stroke team neurologist or neurosurgeon should be consulted for appropriate treatment. A normal CT scan, on the other hand, suggests acute ischemic stroke as the cause of the patient's symptoms. At that point, experts would need to determine whether the patient is a candidate for fibrinolytics and to decide on a specific stroke therapy. That brings us to the final link in the stroke chain of survival: rapid diagnosis and treatment in a hospital equipped for acute stroke patients. This is also the sixth D in stroke care: decision regarding treatment. It begins by using the fibrinolytic checklist to see if the patient is a suitable candidate for fibrinolytics. Hospital personnel should also repeat the neurologic exam to determine whether the patient's condition has improved. Finally, ED staff should review the data to make sure the time from symptom onset remains less than 3 hours. This represents the window of opportunity for the use of intravenous fibrinolytics.
Mrs. Breeze, this is Dr. Gardner, our stroke expert. Yeah. Now your CT scan, it came back normal, which means there's no bleeding in the brain, which is a good sign.
Oh, Mom, that's very good news.
Now, I'm going to leave you with Dr. Gardner. She'll take very good care of you. I'll see you later.
I'm still concerned about your condition, but I just have a few more questions to help us determine whether you've had a stroke, okay? Can you lift your arm for me at all? Has the weakness improved any? Okay. How about your right leg? Are you able to move it at all now? Can you feel that? Mrs. Breeze, can you read this first sentence for me?
So, no.
Okay, well, here's what we think is happening. The sudden onset of the numbness and weakness that you've been having is often a symptom of a stroke. This is caused by a blocked artery leading to a portion of your brain. Evidence from the CT scan seems to support this because the CT scan is normal in the early hours after a stroke. Now, we're able to give you some medicine to help with your condition, but I need to ask you a few questions about your medical history. Your daughter can answer for you, okay? Okay. Has your mom ever had a brain hemorrhage, stroke, or abnormal blood vessels in the brain?
No.
Okay. Any recent bleeding anywhere or history of clotting problems?
No.
Any recent surgeries or accidents?
No.
Okay. History of diabetes or any prescription medications?
No.
Okay. All right. Now, today when the symptoms appeared, did she seem to have a seizure at all?
Nope, not at all.
And she's never had a heart attack?
No.
Okay.
Well, we got the blood work back and everything's normal.
That's great news, Mom.
Yes, it is, Mrs. Breeze. I'll see you later.
Dana, what's her current BP?
192/114.
Your blood pressure is still a little high. We're going to give you a drug to help bring it down. Okay, let's get her 10 milligrams of labetalol and try to keep her systolic blood pressure below 185 and the diastolic below 110.
Okay, right away.
If the patient's medical history is acceptable, if the time of onset is generally less than 3 hours, and if the patient's current condition can be managed within suitable parameters, it's time to move to the next D of stroke care: drug. Fibrinolytics may break up the blood clot in the brain, potentially restoring or improving blood flow to the affected areas. Studies show that these drugs can improve the chance of recovery by 30%. This is the time to discuss drug therapy options with the patient and family members.
Dana tells me we've got your blood pressure down to 175/100, and it's been about an hour since your first symptoms, so I think we're ready to proceed. Now, we're going to administer a medication to help dissolve the blood clot we think is causing the stroke. Now, it'll take about an hour to administer the medication through your IV. There are some potential serious complications that may occur that I need you to think about. Now, there's a possibility, a small possibility, of a cerebral hemorrhage. Now, that's bleeding inside the brain. If this occurs, your situation could get worse. It may even possibly be fatal. Now, it's a small possibility, about 5%, but it is a real possibility and you need to consider that.
What do you think, Mom? Okay. Let's do it.
Okay. Dana, based on her weight, let's administer RTPA according to our protocol.
Okay.
And let's get her a bed in the stroke unit. And I want updates on BP and neuro every 15 minutes until she's transferred. And I want to know of any changes to her neurological situation.
Okay, will do.
Thank you. Ms. Breeze, we're going to take care of you.
Hospital personnel should administer fibrinolytic therapy within 3 hours of symptom onset. Patients who do not meet the time criteria for IV fibrinolytics may be candidates for other forms of acute therapy, including intraarterial RTPA at some stroke centers. For optimal recovery, hospital personnel must carefully control the patient's blood glucose levels, temperature, and blood pressure. For patients who feel the risk of fibrinolytic therapy is unacceptable, healthcare providers may use aspirin and begin the stroke pathway.
The final D in the 8 Ds of stroke care is disposition. This means rapidly admitting the patient to a stroke unit or critical care unit. The development of comprehensive stroke centers ensures best practices for stroke care. Patients experience improved survival rates and better functional outcomes and quality of life when treated by a hospital that specializes in stroke care. Remember the stroke chain of survival and the 8 Ds of stroke care: detection, dispatch, delivery, door, data, decision, drug, and disposition. By rapidly recognizing the signs of acute stroke and preventing delay in diagnosis and treatment, the patient's chances for a full recovery are considerably higher.
Okay, Jane, just 2 more steps. You can do this. 1, 2. Good job.
I'm getting stronger.
You're looking great, Mom.
Oh, I'm feeling great too. I get better every day.
I have to tell you, you're so lucky that your family was able to recognize that you were having a stroke and called for help right away.
I have a lot to thank them for. And the doctors and nurses here really know how to treat a stroke.
I know the staff has really made some changes in how quickly they treat their stroke patients. We're seeing some great outcomes, just like yours.